Hi, good afternoon, everyone. I don't have a podium, which is much better because I like to move around and interact. And my toughest job today is to keep you people awake after lunch on a very dry topic like coagulation. But I thank the organizers and the people who have got me here to give you this small talk on the basics. They said this conference is all about basics. So I'm going to talk about little basics and how to approach a bleeding patient. The assessment of these patients is a multi-step process. We must remember that there has to be a complete detailed history. You can't do hematology and especially coagulation without any clinical details. It's absolutely necessary. Second is thorough physical examination, which also a clinician is supposed to give it to you. Unfortunately, the first two red ones are never given to us when we are sitting in the lab. And we have to, that's why, pay attention to our patient when the patient comes there. Request that the patient should come to you for drawing of the blood sample so that you can plan the last, which is the relevant laboratory evaluation. What is the approach? How we approach a pathologist must see a patient. It's absolutely necessary. Hematology, as I said, you can't do without the detailed examination, history, examine the patient, and plan the investigations. There are hundreds of investigations. You can't do all the investigations in that particular patient. So you have to be choosy and be very, very conservative and do only what is necessary for that patient. What we call clinically, when you see them, I'm sorry, the pointer here is not working, but it's marked. Petechiae are less than 3 millimeters, 1 millimeter mostly, and purpura is about 3 millimeters, less than 5 millimeters, and then you have ecchymosis, which are larger than 5 millimeters. These are pointing towards a platelet defect. Can be platelet number or platelet function. On the other side, it can have the same features in vascular problems, what we call vascular purpura. When you have deep-seated hemarthrosis or deep-seated hemorrhages, hematomas, then you are actually looking at a coagulopathy, and you must keep that in mind. What are you going to do? So you have to talk to your patient. Petechiae, ecchymosis, mucosal bleeding, you've seen a platelet problem. Large bruises can be coagulopathies. And large spleen, possible congenital infections, secondary causes, erythroblastosis in babies. And if jaundice is there, you are looking at a liver problem, which is the seat of production, the factory of all these coagulation factors. Sepsis is another important thing whenever you're looking at babies and children. To begin with, a clinical history cannot be stressed upon to find out whether it gives you the congenital or acquired, because if the problem since birth, after birth, or has it been acquired later on? That points towards inherited, congenital, or acquired causes. Or is it secondary to something else? Family history of prime importance, especially in coagulopathies like hemophilia. So you must ask the family history, especially of uncles, aunts, mothers, and anybody in the family, sisters, and especially for VWF and hemophilia. Draw a family tree if you can, it definitely helps. Examination, as I said, if there is hepatosplenomegaly or lymphadenopathy, you are looking at a secondary cause, not an inherited or congenital problem. Where is it bleeding? Is it always bleeding at the same site, or is it a hemostatic failure all over? So you have to decide whether it's a local cause or is it a general problem. How often do they bleed? If it is spontaneous or is it post-traumatic? How much do they bleed? And do they require any transfusion support or any support with factors or anything else? What is the type of bleeding? Is it petechiae, purpura, or mucosal bleeding? If that is the case, you are looking at a platelet disorder mostly. If it is hematomas, hemarthrosis, you're looking at a coagulation factor deficiencies. Drugs histories cannot be emphasized more because there are certain classes of drugs, these which I have listed here, a few, which we know affect the coagulation process, either in the factors or in the platelets. So please take a detailed history of drugs in these cases. How do we report in our institute? A coagulogram. What we do, once the patient comes, history taken, examination done, we start with the CBC, which is to look at the CBC mainly counts to rule out any other hematological problem, leukemias, lymphoma, or any other pathology which may be there in the CBC. And of course, the platelet number and platelet morphology. Bleeding time, clotting time, platelet count, and platelet morphology. Clot retraction, prothrombin time, activated partial thromboplastin time, thrombin time, and not to forget the last but very important clot solubility test. That is the battery, how we go and collect the sample from our patients and try to reach at the diagnosis. These four are usually the ones in red are telling us about the platelet problem, either the number or the quality of the platelets. These four at the bottom are the coagulation factors, which are any of the 13 factors which may be there. How do we report? Our report is like this. It contains all these elements with the normal values, and what is most important is to the last word. Please pay attention. You can't do any test in pathology. If you are a pathologist, you are consultants, and you have to give an opinion. What does that test mean? If you think your clinician can decipher those, then you're wrong, because it's not his job. It's your job to interpret all the values, whether it is CBC or coagulation, and what does it mean to the patient and to that clinician. So the last impression is very, very important after you have done all these battery of tests. We know bleeding, being a platelet function, the number, we know the normal number, 150 to 450,000. Thrombocytopenia, anything below 150. Spontaneous bleeding can occur from less than 20,000. If you have giant platelets, you will start thinking of probably an immune or what we call idiopathic or immune thrombocytopenia. If the platelets are very small, then there is some marrow failure production defect. You're looking at some marrow failure syndromes. They will bleed on injury if the platelet count is less than 50,000. And if a patient comes to you with the platelets more than 40,000, 50,000 and is bleeding, then you are dealing with probably a platelet function defect. The spontaneous bleeding rarely occurs below, above 20,000, 40, 50,000. You should not have spontaneous bleeding. Hemogram is smear for morphology of the platelets because it gives you the size, although your CBC will give you MPV, but look at the morphology. Look at the granules. And many times we have picked up gray platelet syndromes in our peripheral smear because you look at the morphology of the platelets. Many times you will feel probably it's not stained. There is some staining defect. But if your WBCs and RBCs are stained well and your platelets are looking very pica, faded, then please think of a gray platelet syndrome. It is rare, but not that rare if you look carefully. Bleeding time, clotting time, the usual methods. platelet counts, morphology, and the last 4 are the coagulation factors, the 13 of them, which are going to affect all your coagulation tests. A little bit of classic coagulation cascade, just to recapitulate. I'm sure every one of you knows. I'm sorry, my pointer is not working. On the right side, as we have been taught, and we always remember the extrinsic and the intrinsic system. Extrinsic starts with the tissue factor, factor 7 complex, activated and coming to the common pathway, factor 10. On this side, intrinsic coagulation pathway, which starts with factor 12, which activates because of the activators. And it comes down to 11, 9, using 8 platelets and calcium, again to the common factor 10, the common pathway, which comes to activated 10 prothrombin to thrombin, but in between, not to forget, factor 5, which with the help of platelets and calcium is activating factor 10. Prothrombin to thrombin, fibrinogen to fibrin, and then fibrin stabilizing factor, which is factor 13. So that is your complete classic coagulation cascade, classic. This does not happen inside the body. This is what is actually happening inside the body. You see that factor 12 is out. It has no role in the normal coagulation cascade. And look at the interaction between factor 7 complex tissue factor going to activate 9, and look at the way thrombin is activating 11. So that is what is physiologic coagulation cascade that is happening, and there is a lot of interaction between the extrinsic and the intrinsic, as we call it. There is nothing like intrinsic and extrinsic inside the body. We are thankful that in the laboratory, it is classic coagulation cascade which works. Because if there was interaction between these two, you will never be able to decipher your tests. Now, classic coagulation cascade, as I showed you, the one which is prothrombin time, which is put on the red, you can see it is factor 7, tissue factor with the complex, activates 10, comes to common pathway and forms a clot. That is the prothrombin time. It's a small pathway, it quickly clots. So you have 11 to 12 or 13 seconds for your normal coagulation prothrombin time normal control. Now, if you look at the APTT, it has to travel quite a lot. It is not so short, and that is why your APTT is longer. You have anywhere from 21 to 31 seconds, depending on what factor, what reagent you are using, what is your technique. I will just come to it and you will understand it. So that is your APTT pathway, and once APTT is clotting last fibrin, you know that all these factors are present. If it's a normal APTT, all these factors are present except factor 7. Everything is present if your APTT is normal and your prothrombin is also normal, then everything is normal. But if your prothrombin is prolonged, then the only culprit is factor 7, because all others have been tested by your APTT. The only thing is, both these tests do not take any action or cognizance of factor 13, which is out of PT as well as APTT. Did you see this? This is prothrombin time, nothing to do with factor 13. And we know factor 13 is a very serious clotting coagulation problem. That is why you can't miss it. That is APTT. So look at the third test, which is thrombin time. Thrombin time is doing nothing. It is just saying that fibrinogen is present and it clots immediately, usually from 7 to 10, 11 seconds. That means fibrinogen is normal and it has made the clot, because our endpoint for all these 3 tests is clot formation. Okay, all 3 together, but poor factor 13, nobody is bothered. All 3 tests have not even taken cognizance that there is factor 13 which bleeds. So your patient may be factor 13 deficiency. You will say PT normal, APTT normal, TT normal, okay, bye-bye. Fine, the baby is okay. No, he's bleeding. So you have to find some reason. And if you have not tested for factor 13, you have not tested your complete coagulation profile. Look at that. PT, APTT, everything has tested, but poor factor 13 is left high and dry outside the purview of all the 3 tests. And for that, you have to do clot solubility test, which is urea solubility test using 5 molar urea solution. Now, neonates are a very special population. You have to remember certain things for adults and certain things for children. And neonates, we must remember that coagulation proteins do not cross placenta. So उनका जो है वो अपना बनाया हुआ है, वो बाहर से नहीं आता है उनको, मदर से कुछ भी नहीं आता है उनको. They have to produce their own factors. Plasma concentration differs markedly from adults. They are less than 70% of the adult value, and increased levels of only 2, factor 8 and von Willebrand factor. Lower levels of antithrombin 3, protein C and protein S, increased levels of thrombomodulin. Look at this. Please pay attention to this table. There you have an adult prothrombin time of 12 seconds. A term baby will have 13 seconds. A preterm will also have probably 13 to 14 seconds. But look at the APTT. APTT is very different. 33 seconds to 42 to 53. But that 53 is normal for that preterm baby. Don't start investigating a baby at that level. Please remember, in our labs, we do not have every day a neonatal control sample. What are you comparing against? You are comparing against an adult control value. All your MNPTs and everything is all adult, 20 samples collected. Nobody will bring a normal, healthy baby to give you a control sample. So please keep this in mind, not to investigate APTT. Even up to 2 times in a preterm baby. Don't investigate for factor 8 deficiency and all the intrinsic factor deficiency. It's useless. Wait for some time. Let the baby mature a little. Thrombin time, not much difference. Fibrinogen also not difference. But look at prothrombin time. It is almost 1/3. Factor 2, prothrombin. Factor 5, little bit. Factor 7 and factor 8 and von Willebrand are the only 2 which are little above the normal. Probably nature wants to compensate. During delivery, if the baby has all factors low, he will bleed. So it's better to compensate by increasing factor 8 and von Willebrand, so that little bit of compensation happens and the babies do not bleed at birth, normal babies. Look at these 4. Look at the level. They are almost 1/3 the normal level in term and preterm babies. So it's very important for you to know who is your patient, how old is your patient, and what is the sex of that patient. Whenever you are investigating a case of a neonate who comes up with a whole lot of bleedings and hemorrhages. If it's a well baby or sick baby, you have to know, because there are certain things which point more towards if it's a well baby or a sick baby. How the labor has been, prolonged rupture, fetal distress. Maternal state of health, very important. Infections and Is there any autoimmune process? And what is the platelet count of the mother? Is she ITP? Is she going to transmit the antibodies to the newborn baby? So you must know mother's platelet count. Has the baby been given any vitamin K injection? And is there any hepatosplenomegaly? Because that points towards certain congenital infections which can bleed. So you must know what is happening to that baby. So a healthy baby, if you have, you will think of all these conditions. And if it's a sick neonate, you will look and find out whether there is any infection, DIC, or liver failure. Many healthy neonates may have any one of those, which may cause little bleeding in these cases. Thrombocytopenia. First, we are thinking of platelets, the number and the quality of platelets, the function. Now, thrombocytopenia can be due to any of these causes. I'm not going into the detail, it's given in the textbooks. How to approach the algorithm, it's there. Can you read it at the back, or maybe it's not very clear? I'm sorry. Then what I'll do is, this is automated platelet. Please confirm whether it is spurious thrombocytopenia by doing, seeing the EDTA smear. Is there any EDTA clumping? Is there any EDTA clumping which is happening and giving rise to spurious thrombocytopenia? It's a must. Thanks. You have to rule out whether your platelet count is correct or is it spuriously low. So that's the first step. That is there any obvious reason for thrombocytopenia in the form of any recent chemotherapy, radiotherapy, any splenomegaly or hemodilution? Okay, in that case, yes, no further testing is needed. Don't do anything to that patient if you have a reason for thrombocytopenia. On the other side, if you don't have any, I have the pointer now. Okay, great. If you don't have the, I forgot, it's been put up. Great. So if there is no reason for the patient to bleed or to have thrombocytopenia, then you must perform a bone marrow to find out if megakaryocytes are present or not. If they are decreased, are they examined infiltrative disease or is there aplasia? Why are they decreased? If they are normal or increased, you are probably looking at some other causes. So look at the other elements of the bone marrow. If other elements are normal and megakaryocytes are increased, you are probably looking at this group of disorders, which is peripheral platelet destruction, can be due to any of these causes. And of course, if you don't have any of these, then maybe ITP. On the other side, if you have abnormal other marrow elements, then evaluate for primary hematological problem, and that may cause the bleeding or thrombocytopenia in that patient. Thanks. I like this juggling. Keeps you awake. I don't want you people to sleep. Okay, great. So what are the acquired disorders which can cause bleeding and usually thrombocytopenia? There is a whole list of these cases, and which you people can look up anywhere. There's nothing special about this. Low platelet counts. How do we approach the algorithm? Again, you have normal spleen, no organomegaly or splenomegaly. If splenomegaly with low platelet count and you have a normal marrow, you are looking probably hypersplenism, congestive splenomegaly, liver disease, storage, or any of these problems, which is usually the abnormal sequestration. If the marrow is abnormal, splenomegaly, what is the problem in that marrow? You look at that, it's a combined disorder. Normal spleen with a low platelet count, and you have an abnormal marrow. Can be any of these. You can have aplasia, refractory anemias, pre-leukemias, metastatic cancers. There may not be any splenomegaly. And if normal spleen with normal marrow, then there is excess destruction, can be immune, drugs, or idiopathic. And if it is not, then non-immune, sepsis, vasculitis. Look for other defects. So that is the algorithm one follows in a case of low platelet count. Now, Quickly, I'll run through the coagulation studies, the quality issues. I've been told to finish in half an hour, and standalone labs, how to do the coagulation control, the quality controls. Issues that are there, many issues are there which are pre-analytical, analytical, and post-analytical. There is no other test in hematology or any pathology which has these three, which are so variable and so important for your test result. You have to take these three into account, and then you will realize that. The first test, first line test, which we have done just now, is they should be reproducible and accurate. So attention has to be given to blood collection, processing, selection of the reagents, and what are the tests you are going to do. How do you prepare and store your reagents, controls and standards, and you have to be part of a national or a local quality assurance program. It is absolutely necessary that you have to participate in any one of these quality assurance programs. What are the pre-analytical issues? There are certain activities which are connected with blood sample collection and handling. And most one-labor steps are this. That is the pre-analytical. These are the most common. 70% errors happen here. And lack of standardized procedure for patient preparation. Very important. That is why I don't like coagulation tests being outsourced. Send the sample outside your city. Send the sample to another lab. Better to say, no, I can't do this test. Send that patient to that lab. Because transportation, many of these factors are labile. I have had reports of factor 5, factor 8, 9, 11, all deficient. How can you have that? It is only because of poor transportation. It is because you are outsourcing your coagulation tests. Either do it yourself with proper quality control or don't do it. It's better to take care of all these things. You can see that it affects the patient preparation is very important. How you collect the sample specimen, how do you acquire, how do you transport, and how do you handle and store your specimens. Often outside control, many times, as I said, it is outside the control of many of the laboratories. They just take it, centrifuge it, take out the plasma, and send it away. You don't know what's happening to it. We have had 40 degrees centigrade outside. Is your transportation proper to go to that reference lab? So better to say no or do it properly. Now, patient preparation the patient should be asked to fast overnight and should avoid strenuous physical activity. Very important because that activates certain factors in the body. Avoid cigarette smoking, especially for platelet function defects. Which testing to be avoided if there is ingestion of drugs interfering with the platelets and other coagulation factors. Any transfusions have been given, any factors have been given. What test are you going to do? Wait for 10 days, depending on what you are doing, if you really want to assess and come to the diagnosis of your patient. Factor 13, you have to wait for up to 1 month to say that there is factor 13 deficiency after any of the factors, any of the products, blood products being given. And for thrombophilia testing, don't test them immediately after a thrombotic episode because these patients are already, they have consumed the factors inside the body and they've thrombosed, or they have been put on anticoagulation. So what are you going to test? But the catch is, the clinician says, no, I can't stop anticoagulation in these patients who are clotting inside the body. So what do? You advise them not to do clot-based assays. They can do PCRs, they can do all the other tests, but they cannot do clot-based assays. Coming to the collection, tourniquet should never be applied for more than a minute. directly collect the tube into the anticoagulant, and the first evacuated tube should be the blood coagulation tube. If you are collecting by the winged collection set, venipuncture, discard the first and mix 3 to 4 inversions. Vigorous shaking is to be avoided, which can lead to hemolysis, spurious test or factor activation, and false shortening of the test. You may get a normal test in a deficient, mildly deficient patients. False elevation can occur in the cold activation of factor 7. We all know how it is to be collected. 10 ml of citrated plasma to be collected, 9:1, EDTA for counts, morphology, transport on ice if you are sending from one lab to your main hemat lab in your hospital. 3.2% is recommended. Please follow the manufacturer's instructions. If they tell you to collect your blood in 3.8% citrate, please collect in 3.8%. But most of the reagents that are given, they are giving you how to collect. 9:1, adjust the hematocrit if it is abnormal. Please try and understand this for polycythemic patients and for neonatal babies. What are we anticoagulating? We are only anticoagulating the plasma. The plasma, not the RBCs. A premature baby has 60% RBCs. PCV is so high. How much is the plasma? Very little. And you will again put 9:1. So you're diluting all the factors. So it's very important to know who is your patient, how much is the hematocrit. If you get a false high reading, please keep it in mind. It's very difficult. Very easy for me to say, कि आप दोबारा collect करो. Nobody wants to bleed the patient baby again. Polycythemic patients and premature babies, you must collect properly. If you have an abnormal result, please repeat it. There's no other way. That is the formula which is given in most of the books to adjust the citrate, how much citrate to be taken for how much blood, if the hematocrit is so much. Look at this, 70% hematocrit. Look at the citrate amount is so little. Because in a polycythemic person or a baby, it's very little plasma. It's mainly RBCs. So you're not going to anticoagulate the RBCs. Selection of reagents is very important. You have to pick up reagents which are, what is your need? Are you a coagulation testing lab? Or are you a bad obstetric history supporting your gynecologist for a inhibitor lupus anticoagulant? Please select your reagents carefully. I'll come to this a little later. What are the pre-analytical others? How do you reject some of the samples if they are not identified properly, clotted, contaminated, hemolyzed? Because clotting factors can be activated. If it is collected in EDTA with an inappropriate blood to additive ratio, reject those samples. Proper recollected sample is necessary to perform reliable testing. Some of the analytical issues, now pre-analytical over, in the processing, check for clot formation, centrifuge for, this is the usual thing, 15 minutes to make a PPP with a count of platelets less than 10,000 microliters. All tests to be done within 4 hours. Sample, if kept at 4 degrees, can be kept, but keep in mind cold activation occurs of factor 7 and factor 11. If you have to store, please store with -20 and up to 2 weeks and -70 for 6 months. So you must know what to do with your sample that you have collected. Coming to prothrombin time, sensitivity of this test is influenced by reagents and by the technique used, manual or automated. We are using thromboplastins, which are nothing but a plasma protein, which is which causes conversion of prothrombin to thrombin. And thromboplastin is the combination. Please remember, what we are using in the lab is a combination of phospholipids, tissue factor, and both are needed in activation of extrinsic factor, extrinsic pathway. Now, complete thromboplastin consists of tissue factor, phospholipids. You have removed the platelets. You have centrifuged so well, 10,000 se bhi kam kar diya platelets aapne apne sample mein. But you need phospholipids. So they are provided by your reagent. Calcium chloride to reintroduce the calcium ions. And what is partial thromboplastin? We call it partial thromboplastin time. Partial thromboplastin is nothing but just phospholipids. Just phospholipids. There is no tissue factor there. So you call it partial thromboplastin. Components and thrombin reagent, as I said, these. And how are they sourced? They can be human, placenta, brain, lung, animal source, rabbit, lung, or ox brain, and recombinant. All thromboplastins are available in the market. So it depends on what you are going to standardize your tests in your lab. I'll come to this again because this is a very important factor. Then there are calcium ions and stabilizers. So that is the component which forms your reagent for prothrombin time. Why does variation in INR occur? I do in my lab. International Society says you should have INR because if I do here or there or in Chandigarh, everybody should have the same INR. It has never happened. It never happens because there are thromboplastins are different. Their sensitivity to factors are different. So how can you my thromboplastin, which is rabbit brain thromboplastin, to human placenta or a recombinant? You can't compare. And in spite of all the efforts of International Society, it has not been solved till today. INR is a big challenge. One person gets a prothrombin done in my lab every time. He's on warfarin, very beautifully controlled, 2.5 INR, perfect. We are happy. He goes traveling to his daughter, Nasik, and gets, after a month, gets another prothrombin time done there. Oh, 1.5? मेरा तो वहाँ पे अभी 2.5 आया था. वो या वो गलत है या ये गलत है. दोनों गलत नहीं है. You have been standardized with that reagent, with that method of testing clot, and with that conditions or method of doing. Now, if you want to stay in Nasik, please stay in Nasik, but then let that labs, this thing, follow that. It is very problematic because I tell the patients, आप उधर कर रहे हैं तो आप उधर ही करो, मेरे पास मत आओ. Because they are using another reagent and I am not using that reagent. So your INR is set. Please don't change it. Go to the same lab. So you must tell your patients and educate your clinicians also. MNPT, you people know, we all have to do it. Difference in sodium citrate concentration, low. There is lot of effect of reagent and instrument combination. Absolutely changes the whole thing. And most of the reagents are put with ISI value, but some companies may not be giving you the correct ISI. So choose very carefully, standardize good, reputable companies who ISI doing is a very expensive process for the companies. Please remember that. So go for good companies, they will give you good reagent with true ISI. Blood collection, collect the sample at the same time. आज मेरे पास आया, अभी गोली खा के आया. उस लैब में गया 4 घंटे के बाद गोली सुबह खाई, अभी टेस्ट मेरे पास शाम को करने को आ रहा है. गलत. You must impress upon your patients that please come to me, take your tablet at the same time, come to me at the same time, and if you can't come that day, don't come that day. But come at the same time following the dose because you will never get the correct value. Use the same PT reagents. I tell all my students, I tell all my pathologists, do not change your reagents often. If you are catering to people who are on anticoagulation, choose a good reagent and stick to it. Do not change your reagent. आज ये चेंज किया, आज दूसरा आया, बोला हमारा reagent बहुत अच्छा है, ISI और भी अच्छा है, चलो दूसरा तैयार करेंगे. नहीं, your patients are going to have problem. Don't ever do that. Standardize your method. Your way of detecting clot makes all the difference to this particular test, and your patient's life depends on this. So please do not change your reagents. If you are happy with one reagent, stick to that reagent, but choose from a good company. Is your method manual? Today you are doing manual method, tomorrow automated machine, kal semi-automated? No way, you can't do that. It has to be the same method and the same reagent and the same procedure. So decide what you want to use and stick to that. Method of clot detection, as I said, can be optical or electromechanical. Same way, activated partial thromboplastin time is a non-specific test. We need any activator to start factor 12, to start the cascade. And that is usually done by any one of these. And as I said, partial thromboplastin is nothing but just phospholipids. And many preparations of phospholipids are there again. So choose a reagent with very, very careful selection. Concentration, if you are in a hemophilia lab, attached to a hemophilia clinic, you have a good pediatrician who has coagulation factors, then you better choose a reagent which is factor sensitive. If you have an obstetrician who has a lot of bad obstetric history patients, or a thrombophilia clinic or a neurology clinic which you are supporting, then you better choose a lupus sensitive or inhibitor sensitive reagent. We keep 2 reagents in our lab, always, factor sensitive and lupus sensitive. There are some companies which give you the choice of another 3rd reagent, which is equal in both. If you get that, there are companies which are making one which is equally sensitive factor and lupus. Please choose your reagent very, very carefully. LA-sensitive reagents have low phospholipids, and factor-sensitive have high phospholipids. Mild factor deficiencies may still not be detected by APTT, and you have to choose your reagent properly, as I said. So I keep 2 reagents. So my advice to everybody is to choose and keep 2 reagents, factor-sensitive as well as lupus-sensitive. APTT, we know that. Just remember this little thing. APTT can be increased in these high molecular weight kininogen deficiencies. Factor 12 in the lab will not clot. APTT will be markedly prolonged. Patient will not have any history of bleeding or coagulation problem. And if you do that test with ellagic acid as the activator, it will solve your problem, because that activates from 11. So factor 12 is anyway taken away. Just quickly, use pooled normal plasma, do your MNPTs, use commercial controls, and participate in an external quality assurance program. And IQC is required to ensure that results are precise, and EQA is required to confirm that you are accurate. We are participating with Vellore. They conduct a very good quality control program for coagulations. Anybody can apply, and please participate. It's really good. And anyway, coagulation is this. It is a headache in the lab. To whatever you might do, you will still land up with little pasina here, pasina there. But if you take care of all your issues in coagulation in a standalone lab, you can deliver absolutely correct results, and you can diagnose your patient with whatever may be the problem. Thank you so much. Thanks.